Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Hello and welcome to the El Paso Physicians Show. For the next hour, we will be speaking about a very important topic in our community, trauma. My name is Roy Ortega. We will begin in just a moment. Our panelists today are from the Del Sol Medical Center, and they will be helping us understand the definition of the word trauma, how trauma patients are treated, and how to prevent the most common trauma injuries. We'll learn how to recognize the potential hazards in the home, along with tips on making our home environmentally safer. This is a program that is underwritten by Las Palmas Del Sol Healthcare. We also want to thank the Texas Tech Paul L. Foster School of Medicine for providing a lot of the information that we are about to present to you, and also with the help of some medical students who will be taking your phone calls and answering your questions about this important topic. Actually, we've got two different segments. We're going to be talking, first of all, about the topic of trauma, and then we're going to be speaking about, and also you are, I have your name written here somewhere, Perla Falcone. You are an RN at the Emergency Department of Del Sol. Welcome, all of you. Thank you so much for being here. You know, the topic of trauma is probably one of the most important topics in any hospital. I mean, you don't want to find yourself in a situation where you get hurt somewhere in under some circumstance, but the first question that I have is what really is trauma? What are we talking about here? Are we talking about physical trauma, mental trauma, both of those? Doctor?
Yeah, you're exactly right. It's all encompassing. I mean, when somebody comes into a trauma center, it can come from all walks of life, all types of injuries. It can come from anything from motor vehicle crashes, motorcycle crashes, different types of unfortunate violence, penetrating trauma, gunshot wounds, stabs. You know, unfortunately, we can have drownings, all kinds of injuries. And one of the most common actually in our area is hip fractures. So a lot of broken bones as well.
The one thing that I forgot to ask at the very beginning, can you tell us just a little bit about your background?
Oh, yes, sir,
who
no
you
problem.
are? I think viewers would want to know who their doctors are when they come to be treated.
So I'm Andrew Shea. I'm one of the trauma surgeons at Del Sol. I've been here about 2 years or so. Right. Just moved down here with family. I came from Las Vegas.
Yeah. Dr. Flaherty, a little bit about you.
Sure. So I came to El Paso after a complete 22-year military career. I've been living here for 4 years now. I am a trauma surgeon and emergency general surgeon at Del Sol and the director of the trauma program.
Yeah. And apparently a little bit of background for you?
So like you said before, I am an emergency room nurse. I've been there going on 8 years now. Mm-hmm. So I've kind of seen some stuff here and there. I've served also as a clinical educator, and my latest role now is as a clinical coordinator for them.
Okay, back to the issue of trauma. What kind of training do you have to have? Do you spend during your years training to become doctors? Is most of your time spent in emergency rooms learning about the ways to treat people who are coming in with injuries?
Yeah, it's a really good question. So within general surgery training, you know, after 4 years of medical school and 5 years of surgery residency, you within that spend a lot of time on a bunch of different types of services, learning to specialize in general surgery, but as well as how to operate on what we describe as time-sensitive injuries. So somebody comes in through the emergency department with who's bleeding, anywhere from that to gallbladder disease, sepsis, those types of things. So all of general surgery gets training in those types of injuries.
I'm curious, there is a very definite, well-defined procedure from the moment that person comes into the emergency room. Can you describe what some of those steps are when someone arrives by ambulance or just happens to walk in the door with a traumatic injury?
Yeah, I mean, the very first thing is actually the bystanders, what people do out in the field, which I think we'll kind of get to a little bit later with our, Stop the Bleed program. But, after you get a bystander that can help, then it progresses to the EMS, who are the first responders, saving lives every day, bringing patients in. And then once they bring us to us, that's where we actually have more resources. We've got more people, we've got blood products, assess them in the emergency department. If we take something as simple as a fall, somebody was on some blood thinners and they may have struck their head, unfortunately. Come into the emergency department, we need to make sure that they don't have blood where it's not supposed to be, traumatic brain injury. Depending on how everything goes in the emergency department, sometimes we'll get CT scans to assess how bad the injury is, and then from there, sometimes we'll go directly to the operating room. Other times we give them some special medication and bring them to the intensive care unit.
That process has a name, doesn't it? It's you hear this on television, you triage patients.
Sure.
I don't even know if that's a correct term anymore. But
triage, I usually think of is kind of separating the levels of illness. So somebody comes in very sick versus coming in walking and they're doing okay.
Right.
But if I could just add, I think you bring out a great point, Roy, and that is that these traumatic injuries can be very overwhelming to everybody, including the staff in a hospital. There's a lot of visual things to see that are overwhelming. There's the emotion of seeing somebody who's so significantly injured. And so all trauma centers rely on specific processes to go through so that we know what we're doing and we really are just following our guidelines to tell us what to do. And that starts out in the field with the paramedics. El Paso, Fire and the paramedics out there who do such an outstanding job. And in the broader community with Life Ambulance, they start and then they give us a telephone call or a radio call so we know, have an idea of what we're getting, and we can mobilize our team. That's one of the big differences in a trauma center is we get that early warning notification. We have everybody there on site. That's a big commitment by Del Sol Medical Center to ensure that all of the people that a severely injured patient could need are right there, ready to go. So when we get
have a fairly good idea of what to expect from the paramedics out in the field. Is that correct?
That's exactly right.
You know how to prepare for it.
Because they can tell us what the vital signs are, what they have identified those injuries to be. And that's a very difficult thing for those men and women out in the field, often working in the dark of night under difficult situations.
Right.
So they can tell us what to anticipate. And then Perla and the nurses, we have a very specific room that's ready and waiting in our emergency room. And it's got all of the equipment that would be needed for the very time-sensitive evaluation of these patients. And everybody has a place to stand and a role to do. So that when that patient comes, the team just falls into place on their jobs.
Perla, can you describe that for, when it would, your role as...
Kind of where it goes?
Yeah.
So they're right, it kind of starts out in the field, and the paramedics can kind of, like they said, they sometimes work under very stressful conditions, but they're awesome, and they'll call us up and say, hey, you know what, we have such patient presenting with such injuries, and so us as the team can prepare for that. We can call who we need to call. If we just activate what we call a trauma activation, that calls everybody that needs to be there, to include our ER physicians, our trauma doctors, any personnel we may need from lab or radiology. And like they said, we have our trauma bays are prepped, ready to go. So once we know of this patient coming in, we have our trauma team in-house. So all the nurses, like you said, have a specific role. We know what where to stand, what to do. And then once this patient presents, I like to say it's always the same but different. So the process will always remain the same, but depending on what's going on with this patient, that kind of tells us what we're going to do with them. So if there's something wrong, in step one of the process, we fix that before we move on to step two, and so on and so forth.
I would not think that every single case is the same that comes in the door. I mean, you probably have to deal with a wide variety of types of
Most
injuries.
definitely, yeah.
Let's talk about hospitals and trauma centers. Not all hospitals have a trauma center, is that correct?
That's absolutely correct.
Yeah.
There's a very specific process that a hospital goes through to be recognized as a trauma center. The most important people who make that determination is the state of Texas. At the state level, they have made a determination for what is best for the people in our state when they arrive at a place that's got a sign up that says trauma center. And they rely on the American College of Surgeons to come in and do what's called a verification visit. and look at the care that a hospital is giving to make sure that it is in line with what is expected of the highest standards for a trauma center, and to make sure that all of the resources are there, because this resource commitment is really big. To have the trauma surgeon, there's a trauma surgeon on the property all the time at Del Sol Medical Center. There is an OR team that is completely dedicated only to trauma all the time at Del Sol Medical Center, along with all the other personnel and resources.
Right. And Las Palmas del Sol, it meets all that criteria. It is a fully designated trauma hospital.
Right. Every 3 years, we have a team from the American College of Surgeons in the state of Texas collaboratively come in, and they look at everything that we do and the care that we give before they say, yes, you meet all these standards, and we're going to tell EMS that you're the place to bring injured patients to.
I've heard the term mentioned, level 1 trauma or level whatever trauma. What are the distinctions between those?
So there are 4 levels of trauma centers that are recognized. Level 1 and 2 fall into a common category of comprehensive trauma centers, where they can do absolutely anything in terms of clinical care. A level 1 trauma center would have more resources and dedication to things like residency programs and research. Right. So here in El Paso, University Medical Center and Del Sol Medical Center are the comprehensive trauma centers. We work very collaboratively with EMS to make sure that we're providing coverage for the whole community.
Speaking of that, we are in a part of the country that for a lot of people seems isolated, and there aren't that many trauma facilities of this type in our region. Is that correct?
For 5 hours in any direction,
right.
This is it. We are somewhat of a geographic island. It's almost like being in Hawaii.
And so what happens there? We have an accident that happens in, Van Horn or Fort Stockton or Alpine or Terlingo or anything like that. Those, depending on how the seriousness of that trauma, they end up here, right? They end up in El Paso. I know that a lot of patients are being brought in from New Mexico, even as far north as Socorro near Albuquerque sometimes. Is that?
Yeah, absolutely. Yeah. Once somebody gets within, a trauma system, they need to be transported to the nearest trauma system and hospital that can support their care, and that can be anywhere.
Right.
And we work with those hospitals to help bring them to the highest level of training also. So we go out to these facilities and do training so that they're prepared to handle any trauma that arrives to the best of their ability within their resource limitations. And then we ensure that there is seamless communication to the trauma center at Del Sol so they can get that patient to us.
And I noticed one thing that is very obvious here at Del Sol Las Palmas is that there's a helicopter pad out in the back there. You must rely an awful lot on helicopter transporting people from outlying areas as well, and that's not very common in hospitals here in El Paso, is it? Or
well, it's pretty common for all trauma centers these days because there's such a referral basis, and we talk about the time-distance equation for making a decision about whether somebody should be transported by helicopter or ground. You're right, there does reach a certain point where you're far enough away that the ground is going to take so long.
It's a very serious issue.
Right, and when
who do you rely on for helicopter transportation? Do you have your own helicopter at the hospital, or do you?
No, there are no helicopters here in El Paso. There are agencies that have helicopters that are stationed around because, again, as you might imagine, if you have to go all the way from El Paso out and back, then you're expanding the time. Whereas if the helicopter is more closer to the point of injury where they're needed, we actually reduce that time from the warning of you need to go till we actually get that patient back.
This Del Sol, is it unique in any way? Is there a better reason for a trauma patient to be brought there as opposed to any other place?
Well, that's where Andy and I are.
Yeah, well, that makes sense.
That is true.
Yeah,
that's true.
But do people have are they offered a preference or anything, or is it? How does that work? How does one determine what trauma hospital they're going to El Paso?
Yeah, I mean, when somebody's got an acute injury, depending on how stable it is, they'll come to the nearest trauma center that can take care of them. So we accept a lot of patients over from the east side, centrally. That can vary a little bit. We do have a lot of patients that prefer to come to us for a variety of reasons. But my opinion is we've got a fantastic hospital. Yeah, we've got great nurses. Our docs are on call at the hospital 24/7.
And you have a program that I think probably merits some attention, and that's the Stop the Bleed program. Would you all like to talk about that? What is the Stop the Bleed program, first of all?
Right.
I know we've got some props here that you can show us to demonstrate what you're talking about.
Yeah, the Stop the Bleed program is a national program where we're trying to train as many American citizens as possible. In fact, we would like to train everybody in how to stop life-threatening bleeding. So this sprang out of the school shooting at Sandy Hook. And after that happened, there was a gathering of people led by a trauma surgeon who was also met with people from the FBI, people from the military, people from other sectors of government and EMS. And they came at this from the approach of, well, you know, we're the doctors and we're the medical providers. We really can't stop these shootings from happening. But if this shooting happens, what can we do to reduce unnecessary deaths? And they looked at the types of injuries that happen, and they recognized that, you know what, some of these people die from bleeding that could be stopped if there was just somebody nearby who knew how. And unfortunately, what we find is because there's an active shooter, that the paramedics can't just go charging in there. We know there's injured people in there, but paramedics get held at the fringe because the police is securing the area because they don't want more casualties. So we have to do everything we can to have the best chance that somebody nearby one of these events would know how to stop bleeding. Because compressible sites, bleedings from the extremities, can be stopped by a lay person with very simple techniques and equipment, and we want them to know how. So this is sort of the equivalent of CPR. We want to get that education out there as much and more than CPR is out there.
Right, but it's a very difficult circumstance that you just mentioned how, you know, when the scene is under gunfire or whatever, it could conceivably take a good long while for anybody to even get to the patient. How long do they have if once they start bleeding profusely, I guess depending on where in the body they receive the...
So they can have very little time, only minutes, and that's why we want somebody else who's not a paramedic. The idea would be, you know, if another school shooting happened and an injured child got brought into a room and then the door was barricaded so everybody was safe inside, if somebody inside that room could treat the patient and stop the bleeding, we might have one less death.
Right. Well, could you maybe offer some kind of a demonstration here of how that might work in that kind of scenario?
These courses are being taught around the country now, and we're focused really on two major aspects of bleeding. And one is bleeding from a venous site, which would be treated by packing a wound. And so what we're teaching people is if there's an open wound and there's a lot of blood coming out of it, that it can be stuffed, basically, with any available material, even your T-shirt. Now we have some dressing material here that we're going to demonstrate on, but you know, this is an example of the kind of hole that might be in a person, and we want to teach people how to do that. So.
And Dr. Flaty brought a good point up, you know, kind of about venous versus arterial bleeding. Just kind of in basic terms, you know, vein is low pressure, bringing blood back to the heart that needs to get oxygen. Artery already has been oxygenated in this way out, so it's higher pressure. So this
is that type of bleeding more than the other type of bleeding, or is it they bleed pretty much the same? Or
it kind of depends on where they're at, but an artery you're going to have to use different types of skills. So for a venous bleed, something that's kind of dark maroon color, slow, what we really recommend is if you can take the gauze and pack it deeply, and you're gonna, you know, you're gonna have gloves on. what we don't want you to do is just put it on the top like this.
Most people
That's
would be
the
inclined
goal.
to do that who aren't
That's
trained.
right.
Maybe. Yeah, and it's amazing because these, the venous system that's bringing blood back to the heart is really low pressure. And so something as simple as just packing, this can save somebody's life.
Right. That depicts a bullet wound, I would imagine. And so it would be deep, wouldn't it? It would be.
Yes, sir,
you would be able
exactly.
to stuff quite a bit of.
Yep, and you just put as much in there as you can, and then you can put some over the top and hold pressure. And usually that'll stop something venous.
So this also might be seen in a motor vehicle crash with a large laceration. You know, there's lots of places around here we see people being injured far from El Paso, and we have that prolonged time to get to care. We really need somebody, you know, who gets first on the scene to know how to stop this bleeding. Because if we get somebody to Del Sol who has vital signs and is alive when they arrive, they have a fantastic chance of survival. What we need to do is we need to improve survival out there before they get to us.
Right. Do the first responders get the same kind of training? They know that they can do this as well, right?
So very specifically, this is for non-medical people.
I see. Okay.
Because all of the first responders know how to do this. So the EMTs, the paramedics, tactical police officers like SWAT teams, they all get this kind of advanced medical training. But our challenge is there's not enough of them.
I would imagine that this is as important as knowing CPR. Would you think? You know
that's right. Because you need the person standing next to you to know how to stop this right away.
Yeah. Okay. Apparently, when the patient comes into the hospital, what is it that you do when you see a wound like this?
So we do a lot of things.
Okay.
Like they said, most of the time the paramedics, first responders out on the field will come. Once they bring them to us, we'll have most of this stuff in place already. When we've had patients that walk in and we don't really have a heads up or anything, same thing, you're going to try to pack that wound as much as you can and keep pressure. Right. And there's a whole team of us, so we can actually do quite a few things at once. And always, just activate our trauma and make sure our physicians are there. Right. Our whole team is there.
You know, we do have someone here in the studio who's taking questions from phone calls from the viewers. We're going to get to them in just a moment, but one of the first questions that came in, I think you kind of already talked a little bit about this. They're asking what is the difference between a level 2 trauma center, which it says is Las Palmas, versus a level 1, which is UMC. You did touch on that. Can you expand just a little bit, maybe?
Right, so let me back off just a second. So a level 3 trauma center has significantly less capability than either a 1 or a 2. The level 1 and level 2 capabilities for taking care of patients should be identical. It is identical. Right. But a level 3 has a lesser commitment to the resources. They can't get people to the operating room quite as fast. They don't have as much resources in terms of critical care. That's not what they're designed to do. Now, a level 1 and a level 2 have the same clinical resources and the same clinical capability. So here in El Paso, we have a big teaching hospital downtown that is a level 1 trauma center because they have all of the teaching programs and they have a commitment to research and they're doing all of that work. And for that, they become recognized as a level 1 trauma center. Del Sol is a level 2 trauma center with the same clinical capabilities, would provide the exact same care. We just don't have residents in research.
I don't know if you can answer this question or not, but we are on the border here. Do we have any kind of a formal relationship with the country of Mexico or our friends in Ciudad Juarez to perhaps help them in treating severe trauma patients or anything like that? Is there any kind of interchange or exchange between the two countries, between the hospitals here and perhaps the hospitals there?
So that's a great question, and the answer fundamentally is no, because the border, is a significant, mitigator to getting people from one to the other, and the best part of it really for the citizens of Mexico is that Juarez has a very robust medical system. So if you look at the border from San Diego to Brownsville, really San Diego and here in El Paso are the only places where across the border there is a complementary, very significant, robust medical system, and those patients get cared for very well. At other places in our border, though, we do see a significant flow of patients from one side to the other because the U.S. side typically has very strong medical centers, and there's much less or nothing on the side of Mexico. Now, with that all said, I would also say that the regional medical director for the State Department, who has responsibility for all of Mexico, has made 2 trips to El Paso to talk about how care could be provided best to American citizens who are working at the embassy and things like that. How does he ensure that we can get patients, Americans, across the border to one of the 2 comprehensive trauma centers as expeditiously as possible? We have been talking with him about that, and actually he is working on an exercise to test that as we come across the border. And so we are coordinating with Mexican Emergency Medical Services. We're coordinating with the Border Patrol and the people who control the flow across the border so that we would get patients across as fast as possible.
And there are some very good facilities in New Mexico as well, right? And I know that Albuquerque and northern New Mexico, Santa Fe, and those areas also have their trauma centers and whatnot. So this area is not as isolated, I would think, in terms of the kind of medical facilities and trauma centers that exist, right?
And we also participate in the New Mexico state trauma system, so we have dual accreditation in both states. So really the flow is more from New Mexico into us rather than people from our community, because the nearest comprehensive trauma center is in Albuquerque. Right. Which, as I said, is 5 hours.
It's wonderful that you have this program. How is it offered to the public? Do you have the Stop the Bleed program? Do you have a way of having people, just normal citizens, come in and learn how to do this, or how does that work?
Right, and so as we talked, this is our thrust. We want the average layperson. So we have been teaching this to, for example, school resource officers, to school teachers, to whoever we can get as an audience. And there are courses available at Del Sol. You can go to the Del Sol website and find contact information for our Stop the Bleed courses.
How does someone who's interested, do they contact the hospital directly?
Contact Del Sol Medical Center.
All right, well then we'll go ahead and do that. I know the panel is going to step aside for a moment because we're going to make a quick transition here and talk about another topic very closely related to what we're talking about here. And but before we do that, I mentioned earlier that we do have some medical students from the Paul L. Foster School of Medicine who are on the phones right now taking your questions. If you would like to call in at the moment, feel free to do so. The phone number, I've got it here in front of me, it's 881-0013. If you have a question about any of these topics that we're talking about here, please feel free to call. The doctors here will be very happy to answer any question that you might have. But at this time, we're going to go ahead and switch topics just a little bit and start talking about another program or another topic, and that's how to prevent serious injuries even inside the home. Now, joining us now is Alexis Pereira, and you are the acute therapy supervisor at Las Palmas del Sol. Can you tell us a little bit about your background? What specifically do you do there at the hospital?
Yeah, no problem. So I have my doctorate in physical therapy. I supervise the therapy department in the acute care wing in the hospital. We have physical therapy, occupational therapy, and speech therapy. So we supervise a variety of different needs, especially starting all the way from the ER into the ICU with all of our trauma patients, all the other floors leading all the way up to our ortho floor, where a lot of our trauma patients that have as a result of a fall end up on the orthopedic floor.
So what would be the profile of a patient that you would see directly?
So a perfect one is one that we're discussing is a patient that has come to the hospital as a result of of falling. So over the age of 65 years old, you get quite a bit of increase in falls. It's one of the leading causes of death for individuals greater than 65 years old. So, and 1 out of 200 falls of those 65 to 69 range end up with a hip fracture. And that stat increases to 1 out of 10 falls greater than the age of 85 years old ends up in a hip fracture.
Is that the most common kind of an injury?
It is, yes. It is one of our most common types of traumas. I believe over 53% of our trauma patients are from falls.
Yeah, you mentioned that it seems that there's a large number of falls that result in hip injuries, and I have seen this among older patients that once they sustain that kind of an injury, it's awfully hard for them to come back. How do they come back? How were you able to help them overcome those kinds of injuries, hip injury specifically?
Exactly. Yeah. So, over a third of individuals that fall are likely to fall again within 6 months. Right. And so if it does end up in the result of a fracture, then the patient would then undergo the care of a trauma team. They would have surgery, and then they would usually be in the hospital for about 5 days and then need rehabilitation after that. And so we would continue to work with them within the hospital, and then we would select proper placement after that. And there's a variety of different placements. If the patient's ready to go home, then we could send them home with therapy at home. If not, Del Sol actually has an inpatient rehab facility that we could refer them to the inpatient rehab facility where they would get intense therapy, multiple hours a day of multiple disciplines to get them independent and at their prior level.
And are you trying to get them get back on their feet, and once they start healing and exercising and
yes.
and making sure that they develop the strength, the prior strength, and is that the key to the whole thing? I would imagine the physical therapy is critical.
As physical therapists, one of the biggest things we're looking at is what was your prior level of function. So regardless of what they're coming to us with what was your prior level of function, because we want to get you back to that point. So yes.
Yeah. Is a fall, an elderly person who falls, is that the most common injury that person at that age sustains, or are you dealing with other kinds of trauma with patients in this category?
So certainly the patients who are older than 65 are driving cars and doing other things, and they do suffer injury from other mechanisms. But falls is one of our top 3 injury mechanisms that we see at Del Sol Medical Center.
And that invariably happens in the home. Is that correct?
It happens in some surprising places, but yes, you're right. The home is very common. And in fact, the long bone of the upper leg is the most common bone that we really see fractured, and we call this a hip fracture. And Dr. Shea will tell us a little bit about the anatomy of the hip and that bone and how this happens.
That connects to the pelvis up here, right?
Yes, sir, exactly. So this is a little bit difficult to see, but you've got the regular hip socket. This bone that we've got here, it's on the left, so I'll just hold it on my left side. And when somebody falls, unfortunately, usually they'll hit on the lateral side, kind of this big bone here, this little knob. Sometimes they can hit on the back, and then the bone can fracture in a couple of different places. Sometimes it'll fracture up here where the ball socket is. Sometimes it'll fracture here, farther down at the neck. Other times it'll fracture down here a little bit lower, and sometimes even farther down even more. The repair for this is a lot different than we would think about like a hip replacement or something like a knee replacement. In those types of surgeries, there's arthritis in both the ball and socket itself that they're having to replace. This, or having to fix the bony structures that are connected to allow stabilization. Because as you're putting weight on this, you can see when you put weight here, the different forces are going to be askew if you've got different fractures. So the repair is a lot different.
And at that age, that bone is not as strong as in a younger person.
Yeah, unfortunately that's correct. Yeah, with osteoporosis.
Yeah.
So we're going to talk about that in a little bit here as we work into the conversation, because our concept is we want to take 2 approaches to reducing these hip fractures. One is we want to do what we can to prevent people from falling. And the other is, if a person does fall, what can we do to reduce the risk of breaking? And that gets into the mineralization and calcium.
Well, let's talk about that. How do you prevent that from happening? How do you prevent this kind of an injury among an elderly person?
So that's a great question, because there are many factors that contribute to a fall. Things that you might not even think about. So hearing impairment can contribute to a fall. Vision impairment can contribute to a fall. Difficult areas to navigate in the house can contribute to that fall. And so we want to encourage people to regularly see their primary care doctor so that they can be getting checked out for problems with vision, hearing, balance. Okay, and then we also want to encourage people to look around the home, and I think Alexis can tell us a little bit about some of the common things that can be a trap, including something as simple as an area rug.
I know that there's been a big push among social service agencies to install railings on the bathroom tubs and that sort of thing, but maybe you can elaborate a little bit more on that.
Exactly, yeah. Dr. Flair did a great job kind of explaining some factors. As therapists, we like to kind of look at them in a variety of different categories. So you have some physiological factors such as hearing and such as vision and balance and any gait disturbances, so difficulty walking, or blood pressure, changes in blood pressure, all causes physiological factors that cause falls. If you have some of these changes, we urge you to seek medical care and go to your physician, your PCP, and discuss these with them.
Now, a question about that. Now, those things, can they be cured, or all you can do is manage them, or is there some other approach?
There's a number of different approaches, right? So if it's blood pressure, yes, that can be managed medically. If it's visual or hearing deficits, that can also, there's modifications that can be made. For balance and gait disturbances, that's where exercise really comes in, and that's where seeking, a PCP to potentially refer you to a physical therapist, or even to seek out community programs. There's great community programs, especially for our elderly adults. YMCA has Silver Sneakers program. A lot of the El Paso community centers have different senior programs. There's Tai Chi classes. Tai Chi has been known to vastly increase and improve patients' balance and decrease their chance of falls 43 to 50%. So there's lots of different ways to kind of address those physiological factors.
And I know for a fact that a lot of elderly folks see themselves growing older, and they just resign to themselves to the fact that, well, that's just the way it is. I'm getting old, but you don't encourage that kind of an attitude. I would imagine that you would think you would tell them that, just because you're getting older doesn't mean that you need to have to deal with these issues. That they can be managed very, very effectively.
Exactly.
So,
yep. Exactly.
And I would imagine you talk to them about that.
Yes. Yeah. Just as you can, strengthen your muscles, you can strengthen your balance system, because it's an interplay of a lot of different systems going on. So you can strengthen that balance by working on it. So just as you get older, yes, your vision starts to go, your hearing starts to go, your joints get tighter, your muscles get weaker, but all those things you can address those to then strengthen the overall balance component.
What other types of injuries do we contend with among older patients? Other than the one you just described.
Other than the hip fractures.
Yeah,
so one of the other things we get a lot are actually rib fractures. So we'll have somebody's doing something in the home, maybe it's the middle of the night, the railing isn't quite right, and they just stumble a little bit. So sometimes they'll stumble just enough to hit the side of the counter or something. And sometimes when I talk to patients, I'll tell them that, hey, you've got a few rib fractures and I'm going to admit you to the ICU for a couple of days. Sometimes that's a little bit of a wake-up call, because they realize that just a few rib fractures in an older patient can be a really big deal. Increased risk of pneumonia, difficulty breathing, pain control.
Is it harder to treat an older patient with rib injuries, or as opposed to a younger person?
I wouldn't say necessarily that it's harder to treat. We just have to be very specific. So we have to treat their pain appropriately, make sure that they're breathing well, and then we're getting physical therapy involved as soon as possible. That's one of the keys.
Right.
One of the challenges that we do have is that as we age, we metabolize the drugs differently, and our brain is affected by common medications differently. So while a 20-year-old with a rib fracture, we might be able to give lots of morphine to calm their pain, if we do that in our over 65 population, it's a much different effect, and we tend to see people get hallucinations and altered mental status. So there's a lot of things that have to be watched very closely in managing our older patients.
Does Del Sol have a very specific program, or do you target, or do you work specifically with patients of this type? To make sure that we deal with whatever problem they might have.
Right, so this is not just a Del Sol concern, but really HCA is concerned about this at the national level.
Right.
So at the highest levels of HCA, they are developing and implementing a program that's very specific to the older than 65 population, so that we make sure that we are providing the right care, that the hospitals within HCA have the right resources, such as pharmacists, to review these complicated medicines.
Okay, we mentioned earlier that we have Aaron Pines and Makij Jimena. They are our medical students that are taking phone calls and having folks ask questions. Let me take a couple of these. How long would it take for a patient with a critical trauma injury like a gunshot to be processed? Let's see, patients entering to being treated at a level 1 trauma center versus a level 2 trauma center. Either one of you want to take that one on?
Right, so there's no difference.
No difference.
In either level of those facilities, that patient is going to get to the operating room as expeditiously as possible. I'm going to just imagine that we're talking about a gunshot wound to the abdomen, because that is a very critical, time-sensitive injury. And at both levels of that system, the hospitals would be prepared to have that patient into the operating room essentially immediately. They would make what is essentially just a pit stop in the emergency room to make sure we have good IV access, and we would go straight to the operating room, as would any level 1 trauma center. And it's very common to be able to have that kind of patient into the OR in 10 minutes. No difference.
Yeah, I don't want to run out of time too soon, so I'm going to try to get to as many of these questions as we can. One question: would delivering the Stop the Bleeding program to educators confer liability?
We see no concern about a liability issue with somebody who has received the Stop the Bleed training. This is going to fall under every state's Good Samaritan law, where anybody who is performing this care with the right intent, under the right circumstances, would not be subject to liability.
Okay.
That's a doctor's answer, not a lawyer's answer.
Oh, okay. Yeah. Are there state laws that apply to this in any way? Do you know?
Well, there is the Good Samaritan's law that, as far as I'm aware, exists in every state.
In every state, okay.
Which protects any bystander from rendering emergency care.
How many people work in the operating room in a trauma center? Are there positions other than doctors and nurses?
Oh, absolutely. Yeah, I think we talk about a trauma hospital and trauma system, not necessarily a trauma surgeon. It's an entire group of people. So anywhere from people who are assisting, if we don't have clean rooms, we have to have housekeeping, all the way up to CEO. We've got a lot of people making sure that injured patients get treated quickly. So as far as a number goes, how many people are in the operating room, it depends on the severity of the injury. So I've had 10, 15, 20 people in the operating room caring for one patient.
Do the emergency services in the hospital, are they the largest function in the hospital, or is that how does that compare to the other things that go on in the hospital? Yeah.
I think they are, right?
Yeah, the emergency room is a very big place. We have 50,000 or so people a year who come through the emergency room at Del Sol.
That's just at Del Sol?
That's just at Del Sol.
Okay. Yeah.
Right.
I would imagine that throughout all of El Paso, that number is considerably larger. So.
Right.
Okay. What trauma center would be able to handle venomous bites from snakes, spiders, etc.? That's a good question.
That is a very good question. Our hospital can. Yeah.
How do you treat right now it's snake season in our desert, and I know that there's a lot of people that are confronting snakes while they're out hiking in the Franklin Mountains and whatnot. What's the treatment? What's the course of treatment for someone who comes in with a venomous bite?
So a lot of the times you got to admit them to the intensive care unit because they'll have different blood problems that can happen. We talk about coagulopathies. So depending on a few of the criteria, we'll give them a type of anti-venom. And then when they come to the hospital, we got to make sure that their blood doesn't get too thinned, because that's one of the things that venom can do. Sometimes it can go the other direction as well. So.
Yeah. How well are people trained in an emergency room to deal with spider bites? Do they have to have a fairly good understanding of all the different kinds of insects that are out there? And
well, no, I think they fall into some general categories. But the key is, that the emergency room is staffed with people who are dedicated to emergency care. They have trained in emergency medicine programs, and part of that training is bites and stings. And so they learn what to look for, the signs that something, even if you don't know exactly what bit the person, whether it be a snake or a spider, you know what the important changes are that's happening, and whether that person needs to stay and be admitted to an ICU, if they need to get anti-venom, or if it's lesser acuity and they can go
so
home.
Folks can be assured that there'll be someone there that knows how
there
to...
is always somebody there who is trained in emergency medicine.
Excellent, excellent. How does the trauma unit evaluate a patient's pain? How do they decide how to treat it? Either one of you.
So that's another great question. Pain is very subjective. And so our first thing is, we ask people, are you having pain? And we try to encourage people to try to grade that on a scale from 1 to 10, where 1 is, trivial pain and 10 is the worst pain of their life. And we have different graphs or charts that we can show people for either who don't speak English or who are children and don't communicate or have other communication disorders. We have another scale that's graphically represented. So we can get a sense of how much pain they're having. And then we balance that with the physical signs that we're seeing. There are signs that go along with pain, into blood pressure changes and pulse changes. And we put that all together and determine the best. We like to talk about a multimodality pain regimen. So sometimes we need narcotics, sometimes we need non-steroidal agents, sometimes ice and elevation does just as much as anything else.
Does trauma always involve pain?
I think the answer has to be yes. So trauma is injury. When we
talk
about trauma,
right.
We're not talking about emotional trauma or psychological trauma, that kind of shock.
Right.
We're talking about injury, and every injury is associated with pain of some kind.
A patient that comes in who is unconscious, though, with obviously, body injury of some kind, is it harder for someone to assess the seriousness of their problem because they're not able to articulate the amount of pain that they have, or do you? I guess the procedure that you utilize to assess the patient will tell you exactly what's going on, right?
Yeah, it's true. So depending on the situation, sometimes we will always address the pain. Sometimes it is a little bit more difficult to see exactly how they would rate the pain, like Dr. Flaherty brought up. Right. But the other things we can look at is simple vital signs. When somebody's heart rate goes up, their blood pressure goes up, something simple as pain can be it.
Children with traumatic injuries, physical injuries, how are you all able to handle? Are you well equipped to deal with little kids? Or is that the same procedure, the same protocols as an adult?
No, it's not the same. Children are special in how they're handled and managed. So in the Las Palmas del Sol system, there is a lot of pediatric capability at Las Palmas Medical Center. We have a very robust pediatric critical care team over there who is prepared to take care of those kind of patients. Dr. Sines and his team, they're there and very dedicated to the care of pediatric patients at any level of illness.
Right. So age doesn't matter. If you have an injury of any kind or any kind of trauma?
Well, Del Sol does not care for, we would not admit a pediatric patient to our hospital. Because we have an emergency room, we are prepared to provide the immediate life-threatening care for anybody of any age. Right. But after that, we make a decision to get them to a dedicated pediatric hospital like Las Palmas.
Right. I think we already answered this question. Where can you get the Stop the Bleeding training? You want to maybe just remind people where
So there's a great website out that people can go to. I believe it's bleedingcontrol.org. You can also simply Google Stop the Bleed and you will get all the websites. You can get referrals to Stop the Bleed courses on there. or we can communicate with Del Sol Medical Center, and we will be able to tell people about the courses that we have at Del Sol, or how they can get to another course in the area.
Okay. So there's a very active public information way of in the hospital that you are able to get information to the public about all these things. Is that correct?
That's correct.
I know you have a very good public affairs or public relations. I don't know what they call it in the hospital, but I know they're very active in the community. Is there any type of training available to small organizations on fall prevention and treatment? You know, I worked for several years for social services agencies, and that was one of the things that they were focused very heavily on. So there is that in our community. Can you elaborate a little bit on that?
And I would encourage people again to to contact Del Sol Medical Center and ask for the trauma program, because we are, developing this Don't Fall, Don't Break program, and we want to partner with local agencies to help them get the education that they need and put these kind of programs in place, because we need the force multipliers out there, people who will contact other people and they can contact other people. So really contacting Del Sol Medical Center, asking for the trauma program office, and we will help them get that information in those programs.
Okay. Question about, is there anything that can be done to reduce the risk of injury prevention? There's all kinds of things. I would imagine that, and a lot of things that a lot of injuries that happen, believe it or not, from my standpoint, I think have to do with common sense things. Don't if you're 65 years old like I am, I shouldn't be, climbing a ladder to knock down a branch at the top as part of the tree or something.
Yeah.
So we want to say even things like don't drink and drive.
Yes.
Don't drink and drive. Don't drive distracted. Don't use your cell phone in the car. Those are injury prevention programs. And then there's my mantra to my kids: nothing good happens after midnight.
I agree with you 100%.
And also, as it relates to falls, going back to those different things that you can make, there's home modifications that you can make, such as clearing your floors, avoid those slip rugs, avoid electrical cords running across. Small pets can sometimes be a risk for falls. Places with poor lighting. And then there's personal factors such as the shoes that you choose to wear. Our elderly gentlemen love to wear slippers around the home, and our elderly females love to wear the little sandals with the wedges. And while comfort and style is important, safety first. So making sure you have appropriate appropriate shoes, and just reducing your risk around the home as well.
I would love to see more people take advantage of these things, because I think that's probably the key to ensuring the reduction of a lot of these injuries. Here again, goes back to common sense. It can be avoided. A lot. It's just about all of them can be avoided, I would imagine.
And identifying if you do fall, seek help. Not everyone goes and seeks help once they fall. But as I said, once you've fallen, you're very likely to have another fall within the next 6 months. So trying to identify what caused that fall, especially in the elderly population, is very important. Okay.
Here's a question. I'm not sure what this is. You can answer this. Why isn't more done to treat lymphedema? Is that what?
That's that word, yeah.
Okay.
Lymphedema.
What is it, first of all?
So not necessarily a trauma-related pathology, but lymphedema is where you have different fluid, different parts of your body that's supposed to get brought back into your blood system. And it doesn't. It stays where it's not supposed to. So typical areas of lymphedema would be lower extremities, or if a person has had a mastectomy, sometimes they can get lymphedema in an extremity. Usually we recommend actually different types of physical therapy and some lymphedema garments and such.
Okay. Illnesses. We've been talking about trauma, but illnesses that maybe stem from perhaps some kind of a trauma. How do you define that kind of a problem in a patient?
Well, I think maybe the biggest example for that would be post-traumatic stress disorder, a reaction to how people responded to that crash, or sometimes depression after an injury because of the ongoing limitations that a person might experience. But other than that, it's very rare to have significant medical problems, medical illnesses develop from the trauma. It's more common perhaps for their pre-existing medical problems to complicate the trauma.
See. But are there illnesses, by the way, I should have phrased the question, are there illnesses that develop after someone has a traumatic injury of some kind? No?
No.
Yeah, not
really.
Okay. Now, we've been talking about mostly physical trauma, but there's a whole other area of emotional trauma, PTSD and that sort of thing. Does the hospital also provide that kind of treatment for patients who come in with severe PTSD issues or anything like that?
So we have a robust case management system with social workers who are trained to be able to recognize these kind of problems and to get people to the right resources for management. We rely very heavily on community resources for behavioral medicine, for those kinds of things. We would take care of them in the hospital, take care of their anatomic and their physiologic injuries, and then our social workers would have been working with us all the time to know about these other types of trauma so that we can get them the right resources.
You do have a way of knowing and understanding when a patient comes in that with that kind of severe emotional trauma of some kind. How do you deal with that when someone comes in like that? Yeah.
So as therapists, if we identify that within our patients, we will consult our psychologists, tell the nurses, and the appropriate care will be taken. And when it comes to emotional trauma as well, and kind of relating it back to the falling, a lot of patients that fall then have a fear of falling, and fear of falling can be very debilitating. So that fear often actually causes more falls. They're more rigid. They're less likely to react in the way that they are because they're so fearful. So fear of falling is another sense of where emotionally, and in that sense of a PTSD or that emotional trauma after falling.
Well, we're very close to the end of the show here. We just have a few seconds left, but I want to take the last few seconds to thank you all for being here and educating us on this very important topic. And you all can be contacted there at the hospital. People know where to find you, and so if they have any questions about anything, you'll be able to help and respond. You are with the Las Palmas del Sol Healthcare System, hospital here on the east side. And so, again, thank you so much, and we'll be seeing you again maybe next time on another topic, hopefully.
Great.
All right, and we want to thank everybody at home for being with us here this evening, and I think Catherine Bird will be back probably the next time you see this program. So thanks again for joining us.